Ethics. I am the chairperson, so I have the honor of inviting our session director, Dr. Amol. Please join me here. And I'm going to, before I ask the moderator Vivek to take over, may I invite all the panelists here. Dr. Shantanu Tripathi, who represents clinical and experimental pharmacology. Dr. J.P. Agarwala coming back, representing the radiation oncologist. And then Shekhar Patil, Chirag Desai, B.K. Smruti, Seema Gulia and P.N. Mahapatra. B.K. Mishra, sorry, my mistake, B.K. Mishra. Over to you, Vivek.
So I think, sir, when we are talking about home-based treatment, I think we should stick to safe things like fulvestrant, like trastuzumab, like leuprolide and filgrastim and pegfilgrastim and not venture into paclitaxel and carboplatin. So that is my take. But again, this is another controversial topic as to the science, arts and ethics. I think all these three are very closely linked to each other when a doctor sits in the clinic, and there is often a tussle between all these three factors when we are practicing. So just asking, the Indian regulations. So we listened about Dr. Vijay's study on low dose immunotherapy, where he did a phase 3 clinical trial and proved that low dose immunotherapy is good in head and neck cancers. But in practical world, we are using low dose immunotherapy in many patients. So let's start with you, madam. Do you vouch for low dose immunotherapy in all? Of course, we know we are talking a situation where patient cannot afford the full dose. So do you vouch for the use of low dose immunotherapy treatment in all conditions? We don't have regulatory approvals.
I would definitely add that low dose chemotherapy works, but it will work in all conditions. I have my doubts regarding that, because we have data in head and neck cancer that it works. Theoretically, it should work in all cancer. This is what I believe.
But madam, in your clinic, will you give it or not give it? Theoretically, in your clinic, are you going to give it or not?
I have not given low dose till date. I might use it in future.
Okay, so madam is a yes. What about Mishra sir?
Again, we have just a panel discussion. So there is a point that we can't give at present outside clinical trial as per medico legal. But in case to case basis, in my view, not all case to case basis, after joint clinic decision we can offer with the shared decision with the patient.
Okay.
But there is no blanket yes.
So I may not go for that one, sir, as of today, definitely no.
Okay. Okay, JP sir, low dose immunotherapy in all conditions, what do you say, sir?
Beyond my domain, but still I don't think so blindly, I will say.
Yeah, Amol sir.
If for a patient which is not financially affording and who is, I feel, is eligible based upon biomarkers like PD-L1 or MSI high, I will discuss the data, and if the patient agrees, I will offer.
So again, this comes to, I come to the next one, that again this is about Indian practice, which I still can't understand how good or how bad we are regulated. We have regulatory authorities, but are we thinking that each and every prescriptions that is going in the societies are within the regulations? So sir is saying that there is no, sir is told that there is evidence, there is some scientific rationale of using it and we can use, and there is data from head and neck cancer now. But otherwise, again we have opinions that no, there is no phase 3 trial, there is no phase 2 trial, we can't use it. So what is this Indian practice, sir? I just want to understand what are the regulations, and are we, I mean in UK and US I see that there are strict regulations, FDA is there, EMA is there, NHS is there, everything is happening within strict regulations. In India, are we having practice within strict regulations?
When I go back to Sir's very nice paper of GEM site, low dose versus the standard dose.
So that was clinical trials.
No. So that's what I'm saying. Unless until you have a very solid evidence-based data, to jump whether it is registered, not a good ethical practice. That's what I'm trying to say. So I will not do it.
So in India, like you said, FDA and EMEA, DCGI is there in India, okay? DCGI gives a package insert. In the package insert, indications and doses are written. If you want to do a dose which is different from there, in the interest of the patient, you should document why you have changed the dose. So if I wanted to give the lower dose to a patient, and I find that the patient has diabetes and I am worried that this will cause hyperglycemia and therefore I can give a lower dose, I will document that. If I can't find a reason like this, but I feel that the patient will benefit from low dose, I will prescribe the full dose and let the patient take the low dose. But I will not document my risk of putting down a lower dose which will increase the legal risk for me.
Okay, but sir, can finance be a reason?
Finance can never be a reason. It is right to life is equal to right to health. Right to health is treatment of medicine. Cost does not come into the consideration as far as the doctor is concerned.
Yeah, Dr. Shantanu wants to say something.
Yeah, to me it is very clear, so long it is not labeled indication, it's off-label use. Off-label use is not illegal, but then you have to ensure that it has been explained to the patient properly, and only when you have run out of other options or the context compels you to take this option, you have to discuss with the patient, and finally it has to be documented and you can give. So long you document it properly in the best interest of the patient, there should not be any litigation or any legal hassle. That's
so
it.
Off-label use
Vivek,
can be done, sir. Yeah.
Sorry. No. So what Parekh sir said, and I may be entering into some soup in future. One patient of RCC adjuvant, 100 mg pembrolizumab they could afford. Taking the cue from lung cancer, I explained everything for 2 full pages. Within 4 months, patient had a recurrence. And patient went to 2 other consultants and they said, this dose is not recommended. Why did your doctor give 100 mg? Patient have come to me yesterday before coming.
I'll come to that, sir.
So my point is what Parekh sir said, finance can never be the reason for doing low dose.
But all these years, people who've been prescribed oral medication, how sure are you that they've been sticking to their dosages and not modifying them?
So that is the difference between documentation and reality. कायदा और कानून में फर्क है ना. As far as I am concerned, I have to document what is the labeled dose. Right. After that, whether the patient takes or not is his headache. It is not my responsibility.
Yeah, Shekhar sir wants to say.
So I had a patient recently in head and neck, had a PDL1 positivity. We started an immunotherapy. After 3 cycles, patient is in complete remission. I want to give more cycles, but he says that my finances is not allowing. So after seeing this head and neck data, I just discussed with him. Then he told that is a very good idea, why can't I try this one? So I am giving it, that is an informed consent. Right. That patient has accepted it and I have explained, I utilized this, extrapolated the same data and given. That is how case by case cases we can do it, what I feel.
I think, it is an off-label use, the indication labels are not very clear, but with documentation, there are many using it. In the poll, 76% agreed to using it. So we'll move forward, sir.
Vivek, will you accept low dose radiation?
Sir, again, if you tell me that this low dose radiation will have similar efficacy to that high dose radiation, and you cannot afford high dose radiation, so for whatsoever benefit if you use low dose radiation,
no.
that is beneficial for you.
No. Off-label is off-label. You cannot use. Come on. Off-label you cannot use in good.
No, the point is that
another interesting situation. Let us move.
No, at least it should reach off-label. Yeah. There are a lot of things have not even reached off-label. So whatever that has reached off-label and has a significant some data coming up from various parts, not from India but from China and Japan also, there has to be a discussion at least, and a documentation should be done, and patient agrees should be offered.
Now again, this is another common situation we have where we see that pembrolizumab in triple negative breast cancer or pembrolizumab in RCC is not yet approved by DCGI, but it is, the data has come, phase 3 clinical trial is there, and we are using it, sir. In PDL1 10% positive we are using, but again the DCGI has not approved. Now again, how legal or how clear we are when we are using it, Parikh sir? There is phase 3 clinical trial, everyone is using it, but DCGI has not yet approved.
I can answer that question by taking an example of a real court case. Okay. A lady of the age 46 years went to her GP with burning micturition and fever. What is the diagnosis? UTI, correct? GP said suspected UTI, started the patient on oral antibiotics. One of the known side effects of that oral antibiotics is visual disturbances. Okay. The patient developed visual disturbances. When the case went to court, the judge is asking the GP, why did you prescribe a drug which is banned in United States? It was not banned in India. It is approved by DCGI for use in India. But this is the question that the court asks. So this is the ridiculousness of the judiciary process that we have to face.
I understand, sir, but because of that, we can't stop using scientifically approved treatments.
So let me finish the story. That doctor had to pay 25 lakhs compensation.
But then, sir, these are rare situations. I mean, Shekhar sir, DCGI is not approved, but you are not prescribing pembrolizumab in kidney cancer?
I am using it.
You are using it, but
yes,
DCGI has not approved it, sir.
That may be for insurance or anything if it is required. If
no, insurance is also approving it.
Sir, I faced a similar situation. I had done a laryngectomy plus R&D. That patient developed thermal burns. The judge asked me a question, if you did the surgery, would this incident happen? If you did this surgery, would this incident happen? Because I have done a life-saving procedure for this patient. You are not liable, but the hospital is going to pay for a faulty instrument. Means you have done the surgery, you have caused an injury. The judge is blaming you even if you have done a curative intention part.
Yes. Yeah, sure, sir, sure.
No.
So the process is like this, that the doctor can use a drug which is labeled for approval by the authorities, or it should be supported by scientific basis. Two things are there.
Okay.
So if it is labeled, then there is no problem. If it is not labeled, if it is off label, either in terms of indication or dose, we have to document the reason why we are following it.
So only last day what happened, some of my patient who is now under my care, sheer breast, stage 3C, she is on, she was given neoadjuvant chemotherapy plus 2 biological therapy. Her son is in USA and he is a qualified pharmacist. And he is saying that this should not be used. He is right to some extent. Now, do you think that this is legally not allowed, which is off-label indication for CA breast?
So the relative in United States cannot influence your decision.
No, okay, not my decision, but legal in India,
no,
it is off-label.
It is, I am telling you the legal process.
Okay.
He cannot question you for your decision. You are seeing the patient, your judgment is final.
Fine.
But because it is off-label, you have to justify why you are using, you have to document that.
Okay.
Sir, MSD has not applied for the DCGI yet because it will cost them money. But still, you know, they are selling it and we are using it.
No. I think you are wrong. If it is not approved, they cannot sell it.
No, sir, they are not selling, they are selling for other indications.
Indication is
okay.
They are selling for other indications, maybe. But we are using
so
it.
So in that case, it becomes off-label. In that case, it becomes off-label.
The conclusion is that if it is off-label, you discuss with the patient, document that, and then you can use it if the patient agrees.
Now this is again another situation.
Tell me something. If somebody comes up with some little paper from Romania, Hungary, anywhere, and he says, "Ye paper, this is literature," will it be accepted?
No, sir. I think we have definitions of quality literature and not. And I really don't make a sense of
that's,
our
that's,
law and our victimization
that's
of
the
the
other
law
question. You know,
because,
people in China have more than 50% PDL1 positive. But patients in India, you know the incidence of PDL1 positivity here. So question is this, it's a question of relativity. No?
Yeah. This is another important topic that we have faced in our practice. Now, obviously MSD gives patient assistance program for pembrolizumab, and whatever there are labeled indications which are approved by DCGI, they are giving. But we are using in off-label. Now, it is a drug of 2.4 lakhs per 100 mg, and if you are using labeled, you will get 100 mg free. Yes. So, I want to ask, how many of us have actually changed the diagnosis of the patient to obtain that drug free? So, patient has lung cancer, and patient has Hodgkin's lymphoma, or patient has breast cancer, and we write that lung cancer, and we give that paper to MSD. MSD gives 2.4 lakhs drug free. And how many of have done it? And I have seen many senior colleagues doing it. I have done it myself, because it is a matter of great cost.
No, it should not be done.
Whether it can be done, not done, whether you have done it.
It is forgery, it's crime, it should not be done.
No, we have done it, sir. Basically, in the interest of
Shekhar
patient.
Sir is there. Sir is probably the highest prescriber.
Using the drug off-label is different thing, and changing the diagnosis is a different thing.
Yes. And 21% in the polls have said that they have done it, sir.
So all these 20%, including Vivek and Shekhar, please understand very clearly, you have committed fraud. You have documented that you have committed fraud. You know who has gone to jail recently for 6 months, Malvinder and Shivinder. You will be like that. I can guarantee you that if somebody complains, you will have no defense. Please never ever do that. You are trying to help the patient by putting your reputation and your future at stake.
Absolutely.
So
I refused last month to do this. Company suggested, but I refused.
Yeah, simple. Actually, sir, mare એવું થયું હતું. One of the senior consultant prescribed and the company refused. He said, if you get this printed as a diagnosis, they would give you. I said, no, we cannot do it.
Again, sir, there is very important question of grey market generics. Now, we all know there are grey market generics available which are very cheap, and again, they are useful. And here, sir, we are prescribing, and the documentation is only of the drug that we prescribe. We don't prescribe that you take grey market generics, but we know that the patient is going and buying the grey market generic, and it is working. Of course, the patient cannot afford 1.7 lakhs of osimertinib, and he is buying osimertinib in 12,000 rupees, and he is having response, and institutes are also using it. Now, is there any way we can regulate this, improve the access, use it? How are we going to justify this?
How do you qualify this grey market generics, this adjective grey market? How do you get that?
So first of all, what are we supposed to do? We are supposed to write a prescription with a generic name. Okay? Yes. We are not supposed to write brand name.
Correct.
Agreed?
Correct.
You write the generic name and give the prescription. After that, what the patient gets, where does he get from, whether he has a bill or not, please do not document it. Let him take whatever he wants. Don't take the responsibility of knowing what is there.
So, okay. Amol sir, have you prescribed?
Plausible, it is called plausible deniability. You should be able to deny that you know this fact.
Sir, have you prescribed grey market generics?
No, this is being recorded. Answer is no.
Have you seen it?
Again, this is being recorded. Answer is no. Because if I seen it, then I have to stop it.
No, you prescribe generics. How can you distinguish between white market generic and grey market generic? Who is doing that? So just prescribe generics because that is cheaper. And as on date, so far as the regulatory criteria are concerned, if it is available in Indian market, it should be taken as of good quality, unless it is otherwise proven differently.
So no, sir, these are imported drugs. These are illegally imported drugs.
Yeah, exactly.
That is our,
so this is illegally imported, and I have actually written an article published in a medical journal saying that the Indian government is losing so many millions of dollars because of illegal import of these medicines which are not approved by CDSCO or FDA in our country.
But sir, our patients are benefiting.
So I'm saying now that let the patient take, but the government should be aware of what is happening.
Okay.
Your life and your family and patient life and patient family, choose one. Yeah. Don't. I will with folded hands say don't do.
Okay, so let us come to another important art aspect of our practice as to counseling the patient. So obviously we all have stage 4 metastatic cancer coming to our OPD, and definitely this art of explaining prognosis differs all of us. So madam, how do you counsel your patient when the patient comes and has a median survival of 1 year? So there are doctors who would say that you have 5% chance of cure, and there are doctors who would say that you will die in 6 months. I mean, how do you counsel, how do you tackle this situation?
So first I discuss with the relatives, and to relatives I tell them the true picture, what I am expecting in the clinical.
So you ask the patient to go out?
No, I discuss with the relative, how do you want the prognosis to be discussed with? Do you want to discuss everything in detail with the patient, or you want it to keep it to yourself? Majority of the relatives will say, you please don't tell the true picture to the patient, you explain it to me everything. But I make it a point that I explain it to the relatives in detail, what is the true expected survival, which I think is reasonable in this clinical scenario. I also add to a point that this is what is the average survival. She might have a survival more than this period also and less than this period also, because all patients will not fall into that sigmoid curve. So this is how I explain it to them.
Yeah. I agree with Dr. Seema. There is no point in having sugar coating. Yes, the patient need not be aware of everything, especially if the family wants that. But ideally, if the patient's right to know, but if the family requests, the patient should not be aware of everything. We respect that, but the family should know everything in detail, in black and white. There is no point in having sugar coating. Most of us probably do it maybe to retain the patient, but I don't think so that is the correct way of doing it. We must tell the truth.
Yeah, Hemant sir wants to make a point.
I think my personal feeling is that however much soft corner we have for the patient, this is not the right way to do it. It is, I think, mandated by law to discuss with the patient. There are several conflict of interest in the family happening also. Once you make a diagnosis of cancer and you tell them, इसको immunotherapy देनी है, 6 लाख रुपए खर्च होंगे, तो the son would feel कि he is as it is destined to die. I don't want to get him treated. I will not tell him anything and I will not give him treatment. This decision should be the patient's decision whether he or she wants treatment or not want treatment. Sometimes it is difficult. I mean, I faced it over 30 years, but I think it's high time that we need to change this practice. In the West, in England or US, if you don't tell everything to the patient, you are in big trouble, family or no family.
Sir, in India, there is a big trouble to us if you tell. I remember a patient of metastatic gallbladder cancer whose daughter was a advocate, and she threatened to sue me because the patient was told by the nurse that biopsy has to be done, and she was outraged that why biopsy is done, is cancer suspected. So these are, sir, in practice, in practical world, there are various aspects, and these are all in the extremes. Yes, sir.
So what Hemant sir said, and Parekh sir is also here, and Ullas also was asking, sir, can we have a crystal clear message to this question? We keep discussing in the panel, but I go tomorrow and 90% of the patients' family force me not to tell patient. 1, 2, 3, 4. And in addition to that, what Hemant sir said, my lawyer keeps telling me, you do not use the word death in your OPD. But I do not shy away from writing that patient may die very soon within this time. But I prognosis explained, poor prognosis explained, very poor prognosis, doesn't hold true in the court of law. But sir, we would want a crystal clear message for this question.
Yeah.
So first of all, law expects us not to take away hope from the patient. Okay. Law also expects us that we have to tell the patient irrespective of whether we tell anybody else or not. In the US or UK, we have to take the patient's permission before we tell the spouse also. Okay, that's a different thing. So what I would suggest is what you do practically and what you document may be different. What you have to document is what is the law requires. Now I'll tell you practically what I do. I will first have only the patient in front of me. I will say all the relatives go. And I will ask the patient, what do you want to know? I will not tell him more than he wants to do. There are some patients who say specifically, do I have cancer? Never ever lie to the patient. Okay, so if he says, ask the question here. If he says, is my gant bad? I will say a gant is bad. But then I will not use the word cancer because he is not asking that question. So first we have to be very sensitive to how much he wants to know. The second is I ask the patient, who is your relative with whom I have to discuss everything? And almost 99% of the time they will take the name of somebody, either the wife or the son or the daughter. And then everything in detail I will discuss with that person. So this is my recommendation.
So Purvish, have you ever come across a patient who tells you that I don't want to know?
Yeah.
I don't think the patient ever says that.
No, patients.
No, nobody will say, sir, that I don't want to know.
Arey Baba, you are wrong. I am telling you. There are many patients who will say, doctor, I know I have a bad disease. I have lived my life. All my responsibilities are over. I am happy to die, but I don't want to know.
Dr. Parekh.
So in the heart of their heart, they know something is really bad, but they still don't want to know the details. Then we have to respect that.
So this is what you have told to the patient. What do you document in the file now? And is the signature of the patient required on the undersign of that? That's what I want to know.
So if you are doing an intervention, like giving chemotherapy, biopsy, then consent is required, then you have to write it. Then you have to take the patient's signature. If you are just explaining the prognosis, you do not need to take the sign of the patient. Correct, no problem.
So sir, it is correct to also to tell that you have a 2% chance of cure or 5% chance of cure, don't worry.
Rajiv, I will answer after I make the answer. So, we are not gods. Okay, 2%, 10%, 50% is statistics applicable to 100 patients. I tell the patient that statistics apply to a group of people. For you, everything that happens is 100%. I cannot tell you are going to survive for 3 months, 6 months. I can use the words like good chance, bad chance, poor chance, but I cannot give a specific number in India. In the US, you are supposed to do that, that's a different thing.
Okay.
So I can't agree more with what you said, sir. Sorry, I can't agree more than what you said. At the same time, it's like just to put it in perspective. Another colleague of mine, he writes 5%, 15% chance of death, 50% chance of death. All of these patients come to me.
No, but if you write 5% chance of cure, I think all the patients will go to him. So you know, that is how
actually statistics. I choose not to write the statistics at all. We just say that it's like we write the diagnosis and it's self-explanatory.
You never know, the colleague may be more happy than you.
Statistics is lies and more lies.
Sir, when we talk to the farmers in a center, they want a result. They think if the patient is going to survive for more than 1 year or something like, then they will tell, हम मेहनत करेंगे. अगर बोले इसका result नहीं है, तो we'll stop here. This is the statement of a farmer.
Yeah, I think the patient's literacy education level matters a lot when you are discussing. And there are simple patients where, you know, if you tell them that 6 months is the average survival time, you know, we may lose a good number of patients who would be surviving for 3 years and 4 years. Yeah. So anyways, we'll talk about the next one, that patient referrals, disagreement, second opinions, third opinions. Dr. Amol, I'll start with you because Madam will always give opinion and referral. Madam will seldom take that, so I'll start with you.
So if your question is that if I have given an opinion and the patient has got a second opinion which is different, I will leave it up to the patient that which opinion he wants to follow. If he wants to follow a second opinion, he can get a treatment from the other doctor who has given that opinion. It is a free world and he can exercise his duty. I will explain why I have given an opinion. I will explain maybe the colleague has given the opinion because he may be thinking in that way. Choice is yours, what you want to follow.
Yeah, I mean that's a very rational answer, sir. But let us give another situation where the patient has come to you from a colleague or some other practicing oncologist and he has been given an incorrect treatment, so some treatment which is not there in the guidelines. And now patient asks you that, you know, sir, is this treatment correct? Or, so what are you going to say? Are you going to say that, no, this is an incorrect treatment? Because, you know, that is medical jousting. So will you say that, or how will you tackle that situation? Will you say that, no, my colleague has given a correct treatment only, that did not work, you are unlucky? Or you are going to say that, no, this is also one of the other treatments, but it did not work? Or will you say, no, this treatment is not, sir was saying, sir was there and he said that the other doctor said that this is an incorrect dose of pembrolizumab.
My advice is always clear that do not pass any comment about whatever your colleagues have done. What I practically is do that, see, I am seeing you today, my job starts from today, I can discuss you what can be done further.
Okay.
That
so
is exactly what the words I use.
I think that is a very correct line that you know, you can say that I cannot comment on what has he given.
Can I add to that?
Yes.
The first thing I would say that there are many ways of treating this condition. There are many ways of treating this condition. The first thing. Second thing is, when the previous doctor decided your treatment, what your condition was at that time, what your circumstances were there at that time, I do not know. Today, what is your circumstances, I know. So under these circumstances, among all the treatment options that are available to you, I would suggest that this is the treatment that I want to give you. This is how I would say.
Can I just make a point, please? Yeah. This is a treatment opinion. A lot of time patients go with a histopathology opinion. Let's say we have given Hodgkin's, it comes as PMBCL. Then what do you do if someone can take it? I mean, in our Rajiv Gandhi, we did a biopsy. It happens a lot of times. Hodgkin's lymphoma, you're given one ABBD, patient goes to this thing, वहाँ से biopsy block में PMBCL आया. Now what do you treat for?
Yes, so my answer to such question is very clear, that pathology is not my domain. If two different pathologists have given two different opinions, you go to for a third opinion and go to probably whatever is called as an eminent pathologist or eminent institution. For example, in Bombay, we send it to Tata. And whatever Tata says is considered as final, or maybe Dr. Anita Burgess. So my answer is very clear that unless there is a consensus among pathologists what it is, I'm not going to treat. And this has happened recently. Just a few days back, one non-Hodgkin's DLBCL has been reported as no lymphoma from Tata. So we had gone to the rebiopsy as suggested. So pathology is not my domain. Unless pathologists agree, I am not going to treat.
Okay, so Shekhar sir, your patient tells you that he wants to take dendritic cell treatment at Denvax clinic. Now, what will you tell him, sir?
I will tell I don't know much about that therapy what you are talking. You just find out and take it from them there. Because I really will not be knowing much in detail about that one. I don't want to comment any negative or positive thing. If I have got any other treatment to offer for him, I will tell him. Beyond that one, I may not comment much on that one.
We should not say anything negative about it also.
Definitely.
No, this is a bad, this is wrong treatment, or this has no scientific. We should say that I don't know.
I don't know much about it.
Sir, if we say I don't know, then sir, what are you qualified for? The patient will say that you are a knowledgeable person. How are you saying I don't know?
So, not with specific dendritic cell, what we should be saying, I don't know the positives. These are the possible negatives which has happened. Let's say heavy metals or some XYZ alternative therapy. The compliance to your treatment may change. At that point of time, you have to emphasize that it may not be a smart idea to continue concurrently, because your definitive treatment may have a compliance issues. So you have to caution him that, at least him or her, whatever it may be.
Yeah, practically, sir, we can't say I don't know in the
No, no, what answer generally I give to my patients is that it is your personal choice to do whatever that you feel is appropriate, but in my experience of last so and so years, I have not seen this working, and probably whatever I have seen, that it is a waste of money. So this is my personal opinion, choice is yours.
Okay.
Similarly, they come for Ayurvedic treatment I want
Correct,
to take,
sir,
which will not know. That's the way.
So what you can say is that this is not standard of care. That you can say. And you can say that this is not standard allopathic medicine, it is not my subject, but it is not standard of care. That much you can say. You can't, if you don't want to say I don't know about it, this is how you can say it.
If it changes the compliance to your treatment, you will put your neck out?
So that is the patient's choice. Ultimately, after explaining everything, if the patient wants to go, then my philosophy is the patient deserves the doctor that he selects.
Sir, Shantanu sir, what do you think, just let us coming to this question that, yeah, that is health a commodity or not, sir? What do you feel in today, I mean?
I have a very straight answer, it's not a commodity.
And
it cannot be a commodity.
It depends on to whom you are asking the question.
Yeah.
If you are asking the doctor or if you are asking the judge what is the perception of the doctor, he will say yes, it is a commodity and it's a business.
So
if you are asking the patient, it is not. So whom you are asking is important.
What do you feel, madam? Is health a commodity in healthcare products are business products?
Yeah, definitely.
Or health is like happiness, it's not a commodity. You can't buy or sell health, we have to say like that. But
so do you know that in Punjab, people who are owning nursing homes have got a notice that they have to pay charges for road access fees. What is the road access fees? From the main road to their nursing home, whatever road the municipal corporation has made, for that they are taxing the nursing home. Now, if it is not a commodity, then how can they charge this way?
No, sir, it feels bad to us to say that yes, health is a commodity, or just because we are feeling it bad to say, or in reality what it is, sir, is it a commodity or not? The law takes it as a commodity.
Healthcare products are, but not health.
Okay, so healthcare products are business, products, of course. So again, sir, what do you feel, Shantanu sir, I'll ask you only. Healthcare professionals, as doctors, we own healthcare professionals and business. Is there a conflict of interest in it?
As per the law, you are not.
No, I'm talking about ethics, sir.
It may be difficult. There could be conflict of interest, but you have to address it properly, balance it properly. So you can hold a business, and you can also become a healthcare practitioner. There is nobody is going to prevent you, but only thing is there might be in some situation there might be some conflict of interest which you have to ethically handle it.
What do you call a person, doctor who owns a nursing home? Is that owning a business or it's not owning a business?
Of course, sir, a doctor who is owning a nursing home is
so that is a tradition since 100 years. Correct. There is a problem. It is ethical.
Conflict of interest in it, sir.
There is a distinction between conflict of interest.
25% respondents told that it is unethical for healthcare professionals to own hospitals or engage in business.
So then, there are two things. Many people confuse conflict of interest with interested party. If I am owning a nursing home and I am a doctor that I am treating a patient, I am an interested party because I admit the patient to my nursing home. Okay. When I do that, I have to disclose all the charges upfront, and I have to give the option to the patient, which the patient already has, to go to some other place for treatment. That is being an interested party. The conflict of interest occurs if I have a business that is making chemotherapy drugs, and then I use them to treat the patient in my nursing home without disclosing that to the patient. Then that is conflict of interest.
I'll come to the last things about this.
That is happening,
what
by the
about
way.
GST? What about GST?
That is happening.
Correct.
That I make chemotherapy drugs and I give them to my patients.
Sir is asking about GST.
What about GST? I mean, do the nursing homes have to give GST? And the doctors don't give GST?
You are talking about GST means tax.
Yeah.
The goods and service tax.
Yeah.
So right now healthcare is not under GST. So a doctor does not have to give. But there are certain services that the hospital provides which fall under GST and some which do not fall under the GST. So they will have to have a GST number for those which fall under that GST.
Right. But professional consultations are not under
Not
GST.
under GST as of today.
And what about nursing homes?
So nursing home is like a hospital, right? So certain things in a nursing home will fall under GST.
If the hospital is owning pharmacy, if there is a retail pharmacy, that is under GST.
So bed charges more than 5,000 are now brought
Correct.
under GST.
Correct, correct.
Yeah. And any sir last comments on disclosures? In the West, when we see the presenters presenting slides, they have 2-3 big slides on disclosures, and they are disclosing a lot of things, and which I don't see among Indian presentations. ESMO will tell you that you have to include disclosure before you make any presentation. So why is ICON or ISMPO not telling us?
So
that
today Dr. Hemant Malhotra showed his first slide as disclosure.
No,
Okay,
sir,
for
but
point
it is
number
not
one.
universally happening.
Point number one. Point number two is there is never more than one slide as a disclosure anywhere in the world. It is only one slide, and that slide is shown for 2 seconds. So there is somebody who had written an article that the way that the disclosures are being done are wrong. And I have replied to that with a publication on the fact that Indian doctors, not Indian doctors, doctors are smart enough to understand what is disclosure and what is not disclosure.
But the point is that at least for those 2 seconds the slide is shown. So why it should not be shown? There is no harm in showing it.
In the mail also, they have written that you must have a disclosure slide if you are presenting at ESMO or ASCO. But in ISMPO also or in ICON also, when we are mailing, we never say that you have to put a disclosure.
You went to
slide.
ESMO recently, right?
Yes, yes.
Please tell me what you have remembered from any one disclosure slide.
No, sir, it is not for disclosure, but why do they tell and why it is important?
That is
for them, why it
compliance.
not important for them?
There are so many laws that are regulated there which are not law here. So just because somebody else is making a law, does it mean that it is morally obligation for us to do that?
So that means in India we don't need to have that disclosure slide.
So just tell me one thing. Suppose you were on a speaker's bureau 40 years back. Do you include that in that disclosure?
So the disclosure requirements are specified, and the time frame is also specified. In the last 3 years, in the last 5 years, they are specified. And above a certain amount, above $50,000 per year, it is specified. Then it's a disclosure. If it is not fulfilling that, then it is not a disclosure.
See, a very famous medical oncologist lost his license in the United States.
Memorial Sloan Kettering Cancer Center director.
Yes. He lost his license. He's no more, unfortunately.
That was because his disclosure did not disclose millions of dollars that he got for.
The amount is not the question. The question is even a single rupee.
Amount is specified in the disclosure. If it is less than $50,000, you don't have to disclose it. The amount is specified. How many of us get more than $50,000 in a year? You please tell me.
Okay. I think we have had enough of this discussion. Let us proceed for dinner. So I thank all the panelists and I
Vivek,
thank the audience for active
thing that you had put.
Vivek, one request. Please make these screens a little larger for old people like us to read them. We can't read the slides in this small.
So, can I have your attention please for a minute? Ladies and gentlemen, ladies and gentlemen, so can I have your attention for a minute? Everybody here, I'm here. Ulas, Chief, can I have your attention for a minute? So can we do the general body meeting quickly? All the ICON members are please requested to sit down. For those who are non-ICON members, may I please request you to leave the hall? Only ICON members, please. Thank you.
So, good evening all. I'll read the minutes of the last meeting, which was held on 27th of June in 2022. The minimum quorum was not